Great. Welcome back to House Healthcare. So we are switching gears again, and we have Legislative Counsel with us to review legislation that was passed last year, Act 167 of 2022. Our intent is just to do a section by section description of what is in Act 167, knowing that through the course of this year, we will be taking testimony on all of the sections. Most of the sections require follow-up. So with that, I'm going to turn it over to Legislative Counsel.
Good afternoon. For the record, Amber Navarjali, Legislative Counsel. I'm going to share my screen with the text of Act 167 from 2022. Scroll to the beginning. So first, Act 167 is an act relating to healthcare reform initiatives, data collection, and access to home and community-based services. I'm going to break down section 1 into multiple explanations because there's a lot within just this first section. So first, in subsection A, this section directs the Director of Healthcare Reform and the Agency of Human Services, in collaboration with the Green Mountain Care Board, to develop a proposal for a subsequent agreement with the Center for Medicare and Medicaid Innovation to secure Medicare's sustained participation in multi-payer alternative models in Vermont. So you'll see within just this subsection A, it requires the director to consider multiple things here: factors, models, strategies that must be considered in developing the proposal. So you'll see those here on the first page.
So this is a little bit about what Ina has already been in. Ina Backus was already in to talk to us about with the all-payer model.
So this subsection also outlines what type of alternative payment models and delivery system approaches must be explored. You'll start seeing those on page 2. It's quite the list. There's a subdivision that talks about what elements the proposal must include. This is talking about certain processes to ensure adequate rates of payment, being able to meaningfully impact health equity, and supporting equal access to appropriate mental health care. And it also outlines sort of guidelines for developing the process for the proposal, which has to include a stakeholder engagement process. So you'll see that is going all the way down into page 3.
And correct me if I'm wrong, Amber, everything up to this point is under the direction of Agency of Human Services, correct?
Yes, in collaboration with the Green Mountain Care Board. Thank you. And then starting in subsection B, which is at the bottom of page 3, now we're moving over to the Green Mountain Care Board and its responsibilities under this act. So this subsection directs the Green Mountain Care Board to collaborate with the Agency of Human Services and, using the stakeholder process from subsection A, build on successful healthcare delivery system reform efforts by developing value-based payments, including global payments, from all payers to Vermont hospitals or accountable care organizations, or both. And then you'll see considerations and the goals for this are outlined on page 4. I will just scroll very slowly.
So I'm just going to interject. I hope you don't interject every so often. So the first part was, AHS in collaboration with Green Mountain Care Board moving forward on the all-payer model agreement, things they need to look at in working with the federal government on what that new model will look like. And then the Green Mountain Care Board's work is specific to hospital budgeting within that all-payer model process.
A good segue. So this subsection.
Sorry, Amber, hold on. Leslie, do you have a question?
Well, I'm just wondering, sort of tacking onto your question, does this language allow us to go beyond hospitals, or is it just have to be really that?
So
in terms of global payments is what I'm thinking about.
Right. So this subsection also requires that the board determine how best to include value-based payments, including global payments, or both into the hospital's budget review, the ACO certification and budget review, but also other regulatory processes. So it is beyond just the hospital budget piece.
So we could think about it beyond, that's why I just want to make sure that language allows us to think beyond the hospital. I wasn't sure.
So it's, get to go back.
And that's a good question to ask tomorrow when we're in the meeting with Green Mountain Care Board, because they are doing an update on section 1 and 2. All right, Amber.
All right. Moving into subsection C on page 5. This section requires the Director of Healthcare Reform and the Green Mountain Care Board to report on their activities from the above sections by January 15th. And then you'll see there's also an additional requirement that the Director of Healthcare Reform provide an update rather than a report to legislative committees by March 15th regarding the agency's stakeholder engagement process that was required in subsection A.
This is a newbie question.
Go ahead.
You go ahead first.
I'm sorry, can we move back for a second because my brain was trying to parse something. In B1, it says that GMCB along with AHS, using stakeholder progress, build on successful healthcare delivery system report efforts by developing value-based payments, including global payments from all payers to Vermont hospitals or accountable care organizations or both. And so I guess my question here is, does all payers in this context mean all, like, is it, what's the word I'm looking for here? Is this language effectively directing the GMCB and AHS to make a compulsory involvement by payers in these systems?
It says that they need to build on successful reform efforts that already exist.
Okay.
Perhaps. It doesn't specify what we mean in this instance by all payers.
Okay, just because we use all payer model and
there
all.
are limits to what we are able to regulate as the state or direct the Green Mountain Care Board to regulate.
Okay, great, thanks.
Can I add one thing? Jen Carter. I think also, you know, in what Amber's talking about with the various payers, the Green Mountain Care Board by itself wouldn't have authority to direct most of these payers to do things in a certain way, so it would have to come back likely for legislative action anyway.
Thanks.
Leslie?
I was just wondering, what's the difference between a report and an update?
Most of the time reports are written and it's asked to submit a report. And then updates sort of left open as to how that update is going to be received. If you want to receive a written report, then we write into the language, submit a written report to ensure that it's.
Which I've seen, and what if we didn't need anything formal, but we were worried that the update might go lost into the ozone?
And we asked them to come in and provide us.
So that's up to us.
Yes.
We can't.
Having been the person who actually wrote the word update,
Yeah.
I've used update when it's not a completed process. So it's sort of a progress report. Let us know how things are going, but it's not gonna be a finished product, so there would be no kind of final report.
But it could be written, or, I mean, I just don't want to lose track. I don't know how that stays thought about. That's my thought.
Yep, I mean, an update in this sense, especially because it's to committees and it's during the legislative process, during the legislative session, I think could be a testimony. Often there's some kind of, handout or something that is provided along with it. But some of this language is to give flexibility to the parties who are doing the reporting, whether they do a slide deck or whether they do a narrative report or whether they otherwise provide information.
That's great, thank you.
So next, we have section 2, beginning on page 6, Hospital System Transformation Engagement Process Report. This section requires the Green Mountain Care Board, in collaboration again with the Director of Healthcare Reform and the Agency of Human Services, to develop and conduct a data-informed, patient-focused, community-inclusive engagement process for Vermont's hospitals to reduce inefficiencies, lower costs, improve population health outcomes, reduce health inequities, and increase access to essential services while maintaining sufficient capacity for emergency management. So this section outlines requirements for that engagement process. You'll see they start on page 6. It talks about what should be reviewed as part of the process, providing meaningful opportunities for participation from stakeholders, and then ensuring that the Green Mountain Care Board is providing data and information and analysis that's necessary to support this work. So you'll see that goes all the way down through page 7. And then the section finishes with a report requirement. On or before January 15th, the Green Mountain Care Board shall provide an update on the community engagement process.
And so again, we are hearing testimony from them tomorrow, and there is also a report available.
So moving down into page 8, section 3, payment and delivery system reform appropriations. This section appropriates $900,000 to the Agency of Human Services to support the work in sections 1 and 2, and then also $4.1 million to the Green Mountain Care Board to support the work in sections 1 and 2. Section.
So I'm just going to take a break there real quick, because then we're kind of moving on to another piece. So are there any questions on section 1 and 2? Again, knowing that we'll have Green Mountain Care Board testimony tomorrow.
This is just concrete. What happens if $4 million doesn't get spent in this fiscal year?
So that's one reason why we have a Budget Adjustment Act, right? And then it's something that, again, is part of this committee to make sure that this is moving along in a way that it will be, if it's appropriate, and if it's not, how we decide through a BAA that it's allocated.
Okay, so it would be in the next year, it would recur. Got it.
Okay.
All right, moving on to section 4 and section 5. This is concerning healthcare data, specifically the Health Information Exchange Steering Committee and data strategy. So section 4 requires the Health Information Exchange, also called HIE, Steering Committee to include a data integration strategy in its 2023 HIE strategic plan and to continue its efforts to create a single integrated health record for each individual. And then you'll see moving into section 5, which is lengthy, but these are fairly discrete changes from page 9 all the way down through page 12.
Amory, can I ask you a question, or can I interrupt you real quick? I'm sorry. I think this is the first time we're all seeing, new members are seeing a bill, if I'm correct. So can you explain that, what underlined and crossed out, and if it's not, what that all means?
Yes.
Thank you.
So in this instance, in section 5, we're looking at a specific section within Title 18, section 9410, Healthcare Database. All the language you see here, because it is not underlined and is not strike through, is language that is currently in statute that we are not proposing to change in any way. As you scroll down onto page 10, in subsection E, you'll see a strike through of most of subsection E with then repealed. So that is the language that within this bill, this bill did repeal from statute. Where you see, and also I should note that when language is underlined, that means it is being added. So in this instance, now when you go and look at subsection E, you'll see subsection E, and then the only thing after it will be the word repealed.
Great, thank you.
And I should also say, whenever you see these, you probably can't, you can see them quickly. The asterisks in the middle, that means that we have removed text between these paragraphs because it doesn't need to be in there in order for you to understand what the change is, right? So you'll see that we went from subsection F to subsection H, meaning we took out G just because nothing was being done to it and it wasn't necessary to put it in for you to see what the change was going to be.
This won't be the last time we go through this, so we'll make sure we repeat it.
Also see certain changes in here where it appears like third party that nothing has changed, but actually in this instance, this is part of our sort of conforming revisions we make anytime we're looking at a statute. Third party had no hyphen. Now we are writing third party with the hyphen throughout the statutes annotated So we took this opportunity to make that minor correction. You'll see those sometimes in here, or to capitalize a word or not capitalize a word. But the substance of section 5, here I'm just going to read an overview of it rather than get into the details of it now. So section 5 repeals a prohibition on filing information that is required by law to be kept confidential with the Green Mountain Care Board for the Vermont Health Care Uniform Reporting and Evaluation System. This is referred to as VCURES, in a manner that discloses the patient's identity. But this section retains other protections regarding access to and use of the information consistent with the Federal Health Insurance Portability and Accountability Act, known as HIPAA.
We have not heard from these organizations yet or really talked about the data, so we will get there.
On page 12, we are now in section 6, looking at Blueprint for Health. So Blueprint for Health has 2 sections in here, section 6 and 7. So section 6 specifies that the Vermont's Blueprint for Health initiatives must include quality improvement facilitation and other means to support quality improvement initiatives. And then in section 7, Section 7 requires the Director of Healthcare Reform in the Agency of Human Services to recommend to the legislative committees of jurisdiction on or before January 15th of this year the amounts by which health insurers and Vermont Medicaid should increase their monthly per person per month payments toward the shared cost of Blueprint's community health teams and quality improvement facilitation, and then also provide an estimate of the necessary state funding to cover Medicaid's share of that increase.
And I'm going to interrupt again. So this, we did receive a report. So it is in our legislative report sections. I highly suggest everyone reads it at some point. Well, and I'll tell you when we're going to take the testimony. But this was in the governor's budget. So in the 2024 budget that's coming up, there is money allocated for what came out of this work that they did. And so we will be discussing this as part of our budget process.
Next, in section 8, options for extending moderate needs supports, working group global commitment waiver report. This section directs the Department of Disabilities, Aging and Independent Living, DAIL, as part of developing the Vermont Action Plan for Aging Well, to convene a working group of interested stakeholders to make recommendations on extending access to long-term home and community-based services to a broader cohort of Vermonters and family caregivers. The working group must also provide recommendations on changes to service delivery for individuals who are dually eligible for Medicaid and Medicare. And this section directs DAIL to report the working group's findings and recommendations to the legislative committees of jurisdiction on or before January 15th, 2024. And if so directed by the General Assembly, to collaborate with others in AHS to incorporate the relevant recommendations into Vermont's global commitment to health section 1115 demonstration.
And this section was actually worked on in the Human Services Committee last year.
So you'll see this section actually is rather lengthy, so there's much more details in here on page 14 in terms of what the working group is looking at. So now we are moving all the way down to page 16, section 9. This section requires the Green Mountain Care Board to summarize and synthesize the key findings and recommendations in its reports and post them on its website, and also to develop a standard for creating plain language summaries that the public can easily use and understand. And that is in collaboration with the Office of the Healthcare Advocate.
And since we have the Office of the Healthcare Advocate here, do you mind commenting on this? I believe it's been completed.
Just to focus myself, this is about collaboration on plain language. Is that-
Yes.
Yes, thank you. Paying very close attention, I want you to know.
Yes, thank you. Sorry to put you on the spot.
Yes, the Green Mountain Care Board we have spent some time thinking about this. I honestly think it's Mike Fisher, Healthcare Advocate. I don't think I said that. I honestly think it's something that's going to need sort of continued attention. But yes, we have been in touch with them and would look for your feedback, I think, as you see stuff coming out.
Great, thank you, thank you.
The next section, section 10, on the bottom of page 16, Medicaid reimbursement rates, primary care at 100% of Medicare fiscal year 2024. This section expresses legislative intent to reimburse Medicaid participating providers at 100% of Medicare rates, with first priority for primary care providers, and directs the Department of Vermont Health Access to either include this level of reimbursement for primary care services in its fiscal year 2024 budget proposal, or to provide information on the additional sums necessary to achieve reimbursement parity with Medicare's primary care rates.
So let's stop on here too. So there's no report or anything coming back. This was intent language that we wanted to put in to ensure that we're looking at the administration's looking at reimbursement rates. And so we will expect in the budget that we can ask DEVA to provide this information if they haven't increased the rates. It doesn't appear in the budget as I've seen it, although there's been no in-depth look at it, that this has been done in the budget. So we, again, will be expecting them to then provide the second part, which is the or part.
Again, like Fisher, I would suggest you look at the dental.
Yes, there is a dental piece of it that's in the budget.
Section 11 on page 17 is our last substantive section. This section directs the Department of Financial Regulation to explore the feasibility of requiring health insurers to access clinical data from the Health Information Exchange to support prior authorization requests. It requires DFR to direct health insurers to provide prior authorization information to DFR in a standardized format so that DFR can look at opportunities for aligning and streamlining prior authorization request processes, and tasks the DFR and the Green Mountain Care Board with recommending to the legislative committees of jurisdiction on or before January 15th of this year the statutory changes needed to align and streamline prior authorization processes and requirements across health insurers.
And now I'm going to put Legislative Council on the spot. Did we get that report? Do we know?
Looking, I don't know if you did. I know they were late
Okay,
running behind with some reports.
okay, that's fine.
And so then our last section here is just the effective date. So the appropriations that were made were effective July 1st, and everything else in the bill was effective on June 1st.
Thank you. It seems so much simpler with you going through it that way than what we went through last year.
That's when you skip it a lot.
Right, exactly.
I just remember parsing every single word.
Yeah, that's a lot of work. Questions? Again, we wanted to have this overview since we are meeting tomorrow, a joint hearing testimony with Human Services and Senate Health and Welfare at 9 a.m. to go over sections 1 and 2. The blueprint section will take up as part of the budget process. Section 10 for the Medicaid reimbursement rates we'll look at as part of the budget process. Obviously, prior authorizations will be a priority. So we'll be taking sections of this. We won't be going through it, in one fell swoop. But we wanted to make sure you had a high level overview of what happened. Anything else? Any other questions? Cameron, thank you very much. And since we have a couple minutes, we actually need to do an official vote on Mari as clerk.
Oh, okay.
Wait, no one's running against her?
No, I think you might have missed it.
Do you want me to nominate you?
No.
Do I have to create a record of action for my own
Well, that's,
position?
so what I'm going to do is I'm going to take the vote, I think, and I will call everyone and we'll vote, and then I'll figure out how we need to report it.
Okay.
Does that work?
Yep.
Okay.
You want
So,
nominations then?
if
I'll nominate, I'll nominate
Mari, great. Anyone?
Great.
Have you ever done it before, Mary?
She knows what she's doing.
Should we interview
Yes,
her?
I have.
She's good, she's very reliable.
May I interrogate a member from
Why do you want this position?
Lincoln.
Suddenly went mute.
Just remember, we're still on air, so. It's okay. Still allowed to have fun, even though we're on YouTube. Okay, so I am not going in any alphabetical order. I'm going around the table. So this is the first time we've had to do a vote. So you say yes or no when I call your name. Joe,
Yes.
Alan,
Yes.
Ryan,
Yes.
Alyssa,
Yes.
Tucker,
Yes.
Leslie,
Yes.
Art,
Yes.
and Lori is a yes.
Mari, get to vote.
Mari does, I don't know. Mari doesn't get.
She has to vote.
Yes,
The rules say we have to vote on things.
yes.
Well,
Okay.
on committee on the floor.
Are you sure?
Yeah.
I would have to look at the rules.
Process is the same.
Yeah.
Process is the
Okay.
same. Renee is on the floor, you're in the room.
That's what I thought.
Even though she's voting for herself.
Yeah.
You're not allowed to.
Rule
Okay.
50, I believe, what is it, 75, the one that?
I'll say
I voted for myself to be a
So it's-
legislator.
So it's 902, because we have 2 members out. Thank you very much, Mari, for taking on this. I apologize, I didn't know the rules on how to get that to happen. So that's that. So we will be, like I said, we'll be on the floor at 3, but we'll be back here at 9 a.m. tomorrow for a Zoomed joint meeting, Health, Welfare, and House Human Services. And we can go off air. Thank you, Claire. Thanks, everyone.